Can you all hear me? Boleh kan? Okay, please tell me if you can hear me. So they are premenopausal, of course. They are usually in the childbearing age. They may have careers, they may have families, and of course, treatments are not without any toxicities. So today we're going to talk a little bit about the epidemiology of young breast cancer patients and the issues that they face. And we know that there are many issues surrounding young breast cancer patients. So for example, survival outcomes, where young patients actually do worse than the older counterparts, right? And then we have quality of life outcomes like psychosocial aspects, financial toxicity, and of course, we need to talk about fertility outcomes as well as inherited or genetic predisposition. And in special cases, of course, when they have gestational breast cancer. So for the time we have, which is 15 minutes, we will be covering mainly on fertility as well as genetic predisposition. So what is in the literature shows that only about 6.6% of all breast cancer patients are diagnosed in women less than 40 years of age, and 2.4% of these women are less than 35. And only 0.65% are actually less than 30 years old. Okay. So how do we find the data in our National Cancer Registry? You can actually find it. There is actually raw data on the numbers, which are raw numbers for each decade of life. So I've calculated it last night. Okay, so you can see that the less than 40 years old is actually double of what is seen in the European countries. So about 12% of our patients are less than 40 years old. And those less than 35 is 5.2%. So it's actually double of what is seen in the European countries. And it really is because of the birth cohort. You know, there is a birth cohort in terms of exposure to risk factors. So you'll find that you look at the picture above there, that is our age-specific incidence curve. And you can see that it will go quickly, reaches its peak about 45 to about 55 years of age, and then it plateaus, or it can even go down. That means when you look at that, you say, oh, older women, it's not common to get breast cancer in the older women. Okay, I have seen the latest National Cancer Registry graph, which is not published yet. Dr. Siti from IKN has actually shown it to some of us at the National Task Force meeting. This curve is now almost similar to what we see in the West, where women, as they get older, the age-specific incident actually increases. So you see that the curve actually goes up beyond the age of 60. Okay, in the past, you see this blunting of the curve because these women in the older age group, they were not exposed to the risk factors. So they call this the birth cohort effect, right? Okay, so although our registry shows these numbers at this time, this is very outdated numbers, right? So we don't really know what the trends will show. But let me share with you this very recent publication that was only published this year by the Americans. So they looked at something like 200 over 1,000 women in their SEER database. You can see that the incidence of breast cancer is increasing in the young age group. So this is not just specific for breast cancer, but other cancers as well. We are seeing younger people actually developing cancer in the present moment. So I think you can see from the year 2017, they see this increase in the incidence of cancer in the young, which are people aged 20 to 49 years of age. Okay, all right. So let's go into the fertility issue first. And I always think that, the problem with trying to understand these things that we all forgot our basics, right? So let's just go and reflect again on what is fertility treatments. Okay, so we know that as the woman ages, in the natural physiology of women, the chances of conceiving is actually getting much lower, isn't it? Okay, but however, when women are undergoing treatments, they actually face several issues with fertility. So I thought I'll share with you what is known to be the assisted reproductive technology for infertility. So usually call it as ART. right? So most times when people are needing some assistance in reproducing, we use two things. One is fertility medication to get the oocytes to stimulate the oocytes production, and then later they go into this what we call assisted reproductive technology, where it could be either intrauterine insemination or in vitro fertilization. Maybe this picture is a little bit more easier for us. Okay, so of course, initially what the woman needs is ovarian overstimulation. So we're trying to stimulate the oocytes, and then the eggs are retrieved. And then also for the man, the sperm is retrieved. And then fertilization can be done externally. That's what we call in vitro fertilization. Or it is done within the patient, where we call it gamete transfer, right? Gift. The gamete intrauterine fertilization technique, all right? And then after that, if they have cultured the embryo in vitro in the lab, then the embryo will be transferred back to the woman. And then after that, so forth, hopefully a pregnancy will occur. So you can see that actually there has been expansion in the art. What they have is what we call pre-implantation genetic screening. That means women who are, let's say, carriers of a very catastrophic disease like hemophilia, okay, or even BRCA, they can actually test the embryo to see if there is any genetic mutation before they actually implant this embryo into the patient, right? And of course, with the cryopreservation, you can actually store the eggs forever, you know, in cryopreservation. Okay, so the other way of looking at it, sorry. Oops. All right. So what happens in cancer treatment? So for breast cancer patients, certainly chemotherapy is the one that actually threatens the fertility of the patient. Radiation treatment, not so much in breast cancer, but in colorectal cancer, for example, where they actually have what do you call it, rectal radiation, isn't it? Okay. Surgery, of course, if they have other diseases like maybe endometriosis and so forth, right? Okay, so how do you do fertility preservation? Really is we must know what are the fertility preservation options and what is the impact of the fertility treatment to the cancer as well as the cancer treatments and the outcomes of the patient. And also you must remember tamoxifen as a form of, in a way, making the patient not really fertile after the treatments, I mean, during the hormonal treatment. And again, oncofertility, this is what we call fertility treatments in cancer. It is something that is not usual. You can't really find it, but actually it's available in Malaysia. Okay, let me just ask all of you. How many of you know there is an oncofertility service in Malaysia? See, the rest don't know, kan? Probably about what, 20% of you know? All right, so it's actually available. I will share with you later where are these people, right? And they are usually specialists from the ONG side, lah, not us, lah, okay? Right. Okay, so fertility preservation for people with cancer is usually using the ART, as mentioned just now. And we must remember LH, RH agonists that we use during chemotherapy can also preserve fertility of the patient because it can rest the ovaries during the time of chemotherapy. Okay. And again, interrupting tamoxifen for pregnancy is another way of controlling or allowing the patient to get pregnant even though they are on tamoxifen. Okay, so let's look at the first one. All right, so as usual, I always put up the NCCN guidelines because guess what? This one I baru tengok malam tadi, okay? February 2024. If you want to look for a guideline, look for NCCN guideline. You must all be registered for NCCN guideline because they keep on changing. It's actually 3 times or 4 times a year. So if you want to know the latest, go and look at the NCCN guideline. So what does it say about fertility and birth control? Okay, I'm not going to go into too much detail, but essentially, you can actually discuss fertility with young patients. So anyone below 40 that has a potential to become pregnant or want to be pregnant should be given fertility counseling. And who does it? we have to refer to our onco-fertility colleagues, right? Who is the gatekeeper? Us. Somebody say us, right? Yes, but also don't forget the oncologists. Surprisingly, oncologists refer for men, for young men to preserve sperms, but then somehow women, somehow like, is no routine referral to oncofertility. So I think we as surgeons can actually play a role in this, right? So there are many, many ways of doing it. We will go into more details later, okay? But essentially, I think we must know that if the patient does not have periods, doesn't mean that she's infertile, okay? All right, about 50% of patients who are below the age of 40 will resume their periods within that 2 years after they stop the chemo. Doesn't mean that when they don't have periods, they're not fertile, okay? So you must always talk to them about contraception, right? All right, and then usually, of course, we don't advise them to be pregnant during systemic therapy, okay? And then we'll talk a little bit about whether we can stop tamoxifen while they are on the 5-year treatment or the 10-year treatment, just so that they can get pregnant, right? Okay, and then there are many other things. Okay, please go back and read your NCCN guidelines. Okay. All right. Okay, so oncofertility preservation, what is the process? So first of all, we have to evaluate the cancer patient in terms of their stage. Do you think we would offer fertility preservation in someone who is stage 4? Of course not, right? So usually we would do it in curable breast cancer, right? And then you have to estimate the gonadotoxicity potential of the treatments. So for example, the patient on chemo, especially, chemo is actually the one that actually affects their fertility, right? And then of course you need multidisciplinary planning and the choice of fertility preservation method. We'll talk about it later. 2 minit je lagi ah. Oh, sorry. I'm so slow. Okay. Then of course, these are the different ways of preserving fertility, right? Let me just go to this. Okay. So essentially, there are 2 ways of preserving fertility in people with breast cancer who is going to undergo treatments. So one, of course, is where you can actually do cryopreservation of the ovarian tissues themselves, or you can do oocyte retrieval by stimulating the oocyte to be produced, right? And then eventually, the cryopreservation can actually be just the oocyte or the embryo itself, right? Or as we mentioned, the ovarian tissue itself can be cryopreserved, right? So it is fairly safe in terms of when we talk about controlled ovarian stimulation. And you know what agent is used for ovarian stimulation? It's actually letrozole. Okay, in the past, before there were a lot of trials for AI, a lot of women became pregnant when they were on AI. Okay, because what it does is it actually suppresses the estrogen, and then you have a negative feedback, and then they actually stimulate the, what do you call this? The ovulation. Okay, all right. So please read this. You can do the QR code. See, I made a nice one over there for you. Please take a snapshot of this and find out more about the safety. All right. So essentially, this information here is actually local. This is from UKM. These are our UKM authors, the oncofertility experts from there. What I wanted you to really focus on is if the patient is keen to do fertility preservation, either whether they're single or married, okay, they can have it. Okay, that means single women can also have their fertility preserved, even in adolescents, children. Okay, so they have to be referred to oncofertility experts so that they can actually preserve something for their future, right? Okay, I want you to look at the interval from the primary cancer treatment. So if let's say the patient has time before you want to institute the chemotherapy, like for example, you're having surgery first, right? You have time to do oocyte stimulation or retrieval. There's enough time for that. But if let's say the patient is already like towards the end of the 30-day rule, right? You want to try and get your patient through their primary treatments within 30 days, right? If it's less than 2 weeks, you do ovarian cryopreservation because you don't have to undergo the stimulation part, the oocyte stimulation, right? So that's the difference. This is the timeliness. Is it less than 2 weeks or more than 2 weeks? If less than 2 weeks, they just need to preserve the ovarian tissue. And this is available. I think it's available in HUKM. In UM, I'm not sure. I think what I asked my fertility colleagues, they say is mainly available in HUKM, cryopreservation of the ovary tissues. All right. Okay, sebab kita dah tak cukup masa, let me just quickly go through. So, do you know how much it costs? So, this is the referral pathway in UMMC. They actually put the cost kat situ. For oocyte cryopreservation, it costs 11 to 12,000 ringgit. Okay, because of all the lab work and all the things that needs to be done. If it's embryo cryopreservation, it's about 12 to 13,000 ringgit. Sperm murah lah, 600 sahaja. Okay, alright. Kan? Okay, so I think the genetic aspects, I think I will just zoom right to because I think I don't have to do this anymore. Okay, this is the testing criteria. And actually tak payahlah sebab kita dah tak cukup masa. So what I wanted to show you is this. Another QR code for you to take on. There is a course available on Future Learn. You can actually do this course. It will teach you all about risk assessment. How do you assess risk of your patient? And how do you manage their risk? Alright? So syllabus dia ada 6 minggu sebenarnya. Okay? We talk about mainstreaming. Mainstreaming just means that you, as the cancer doctor, does the genetic test yourself. That means you have to learn how to do genetic counseling. It is not impossible. In the course, we provide you materials that you can bring to your CMP ke quality department to get them to use the documents in the hospital to do the genetic counseling, to do the consent, and then of course where to send your specimens and all that for the testing. And we also do a lot of case scenarios so you can practice in the course. So I think some of you may have taken the course. So you can ask them whether it's good or not. But please, this is available to you. So please use it. So really, we know that you all have seen this, right? You all know how to do this now. Yesterday, Dr. Vaish gave a good lecture about which one you should do neoadjuvant, right? It's all biomarker based. Okay, but is this enough for us to treat our patients? Especially young breast cancer patients. So for anything to happen in your clinical practice, you need to start thinking about the care pathway. How are you going to refer your patients? Because it has to be routine lah. Takkanlah patient A dapat referral, patient B tak dapat. Patient A dapat fertility preservation, patient B tak ada. So you must find a way in your clinical practice to make it routine. Kalau kata patient you 40 tahun ke bawah, inilah benda-benda yang you perlu sediakan untuk diorang. Referral to the oncofertility expert. So we now know dekat HUKM ada, dekat UMMC ada, dekat private hospital pun ada. Okay, so I think in KKM, I'm not sure. But as far as I know, this is what is available lah. Tapi apparently there's 12 private hospital that actually provide this around the country. So you please carilah mereka ni. Because you never know, your patient may really want it. Okay. Alright. Okay, so I think the Chinese have actually done their own protocols already. So you can even check on their protocols. You can follow and see how you can use their protocols in your own practice. Okay, so in conclusion, young patients with breast cancer and patients with BRCA mutation can have a complex relationship with fertility and pregnancy. Multidisciplinary care and setting up referral routine care pathway is critical if you are thinking of setting up the fertility preservation. And how do you plan pregnancy and genetic testing? And usually kan, this thing kita tak buat. Selalu oncologist buat sebab diorang yang plan the chemo. But unfortunately, your window tu is so short. By the time you refer ke oncologist, dah habis dah 2 minggu tu. Then you waste time some more, right? So what you need to do is to have MDT at diagnosis. If this woman is young, she's interested in fertility preservation, you should already refer at that time to the oncofertility expert. Alright? So remember, breast surgeon selalu dipanggil captain lah. Sebab sebenarnya you all yang kena organize macam-macam. So hopefully with this information, you'll be able to change your practice. And the other thing I wanted to mention was with regards to the tamoxifen. I don't know, I must have missed the slide somewhere. There is a trial called the positive trial, where there is a temporary interruption of the tamoxifen in young women to become pregnant. They stop it after a period of about 18 months to 24 months of tamoxifen. They stop it for 2 years to allow the patient to get pregnant. And in that study, it shows that the outcome was actually okay. It was actually similar to people who you didn't stop the tamoxifen. Okay, but remember, any trial, what must you do? You have to look at the patient population. 93% of the patient in that study was stage 1 and 2. So janganlah berani pula stage 3 nak pergi buat pula kan. So you must choose your patient well. If the patient is stage 0, stage 1, stage 2, the risk of relapse is actually low and the patient understands the risk. You can actually stop the tamoxifen, and usually we give a washout period about 3 months, and then the patient can try to get pregnant after that. All right, so usually we can stop for 2 years. Okay, so that was the last slide really. So maybe if we have time, I'll take some questions. If not, I think we can stop here. Thank you.
Thank you so much, Prof. Aishah. We have about 5 minutes just for a quick 1 or 2 questions. So does anyone have any questions? Just raise your hand, we'll come to you with a mic.
So if you can refer for private for the genetic testing, but we don't have geneticists. So
Oh, okay.
qualified for pre-test, post-test genetics?
Okay, so I think this is a very important question, because right now for genetic testing, especially for BRCA mutation, there is treatments available if they are positive. So we call this drug the PARP inhibitors, right? But again, PARP inhibitors is not cheap lah. It's like 12,000 or something per dose or something like that. Okay, but the patient can be offered testing also because you can do the risk management at the point of diagnosis and the initial treatment. Because we know our patients, once they have gone through all their treatments to do risk management, like contralateral prophylactic mastectomy, they may never come back to you to do it until like 10 years later or something, because they get post-traumatic stress disorder. All our patients, 1 in 4 of them will get palpitation when they see you, on follow-up. Okay, because they are stressed. I mean, it's like something involuntary. So if you can manage them at the beginning, okay, you should try to manage them at the beginning. But again, this is a very long answer, It's impossible to do it today. But please, I think you can go for the course. And the course is actually linked to implementation research right now by one of the students in KK, Kota Kinabalu. We haven't got the ethics or anything yet, so please be patient. We will come up with the protocol, because what we intend to do is to find a way to get the test to be cheaper. Okay, right now the test is available. You can actually do it. You can actually send. If you contact Cancer Research Malaysia, they are actually better equipped now. They have more genetic counselors. So if any one of you have patients that you need to do genetic testing, you can refer to Cancer Research Malaysia. All right, they have a number that later maybe we can share with you in the WhatsApp group. That is one way of doing it. The other way is you train yourself how to do the genetic counseling. But again, this is not something simple. Usually you need to be mentored or something like that before you feel confident enough to do it. But it's not impossible, right? In our hospital, kat PPUM, our geneticist is very upset lah when we started this, because they felt that we might cause more harm by doing the testing ourselves. But what we plan to do is a CNP process where whoever wants to order the test has to be privileged to order the test. So that is something in the works, but I'm not sure. It depends on your hospital, how you want to do it. But I have to say, I do it like now quite commonly, because you can get your results by within a week you can get. Dekat Pantai Hospital, for example, you can send it off, and there is a subsidized test now, which costs, if it's newly diagnosed breast cancer patient, only for BRCA 1 and 2, is about 1,000 ringgit. That is subsidized partly by AstraZeneca. But if you do it through Cancer Research Malaysia, it will cost about 1,800. And the other one you can do is refer to HKL. Okay. when we do this mainstreaming, because what we want is to improve access for our patients to do the test, but we know that once you open the floodgates, in fact oncology dah order pun. If you notice, sometimes you get patients who already have the results, but nobody knows what to do with this patient. So they send it to the breast surgical clinic, right? So in order for us to support this, we need our colleagues from medical genetics unit in KKM to help out lah. So what is happening now is that they are trying to organize themselves because they have different places, Penang, HKL, I think Sarawak pun ada, Johor ada oncologist yang buatkan or something like that. So they can organize themselves. So when the time you have done the test because you are treating the patient, if the patient is positive, you can refer the whole family to the geneticist. Okay, so we will be doing some sort of mapping. We are working with Cancer Research Malaysia to see how the access can be improved. And because if everybody wants to do the test, the numbers will increase. So when there's volume, what will happen to the cost of the test? It might actually come down. Okay, so that's what we're trying to work out with a local company, but not so soon lah. I would say maybe in the next 6 months or so. All right. Okay.
This is much again for Aishah.
Okay.
Sorry, in the interest of time, we need to move on to our next speaker. Welcome Associate Professor Suliza from UMS.